Dear students, this session I will be talking about the prenatal diagnosis of genetic diseases. Genetic diseases are divided in three groups when we look at the prenatal diagnosis: chromosomal abnormalities, single gene disorders, and multifactorial diseases. Indications for prenatal diagnosis. When do we need to actually get fetal samples, either amniocentesis or chorionovillous sampling? It's listed in these four categories according to the genetic diseases that I described. Chromosomal abnormality, when you have advanced maternal age, usually the high risk advanced maternal age is about 35 years and older. I will give you the exact age and the risk for Down syndrome, for instance, in the later slides. But we have to be concerned with the older age to diagnose exactly the chromosomal abnormalities, mostly the numerical aneuploidies like chromosome 13, 18, and 21, and XY, the sexual aneuploidies. Abnormal biochemical screening is when we have a prenatal screening test and it becomes high risk. We have to do confirmation using amniocentesis and genetic testing. Previous child with a chromosomal disorder, for instance, if a lady had a Down syndrome baby, for the next pregnancy, the risk is about 1%. And because of this high risk, we usually do not do maternal serum screening. Rather, we should do amniocentesis for genetic testing in the fetus. Balanced translocation carrier for a chromosomal disorder, when the parents are they have balanced translocation. Sometimes they are carriers for 21-21 Robertsonian translocation, which I will talk about later in the slides. We perform prenatal diagnosis. Single gene defects, we have to do prenatal diagnosis when there is a previous child with an inherited metabolic disorder, for instance, PKU. Heterozygous couples detected prospectively by screening programs. In Iran, we have a screening programs for beta thalassemia prior to marriage. And if they are both couples, they are carriers of beta thalassemia, it's mandatory for them to perform prenatal diagnosis of beta thalassemia. Previous child with a disorder detectable by ultrasound. Sometimes in the gestational week 18, we detect abnormalities like achondroplasia or some skeletal dysplasia, and the pregnancy is terminated by doing just ultrasound. But in this case, if we know the type of disease and we know the genetic disorder, we can perform prenatal genetic testing prior to week 18 for the next pregnancy. Multifactorial disorders, previous child with a neural tube defects. Here, the lady probably did not, they have a folic acid deficiency and they did not receive folic acid prior pregnancy and during pregnancy, and a lot of times you have neural tube defects. And for disorders of this type of multifactorial, we don't need to do prenatal diagnosis. We just have to prevent this deficiency by prescribing the folic acid for the lady. A previous child with a developmental defect or malformation syndrome detectable by ultrasound. Here, a lot of time it could be environmental effect that caused the developmental defect or malformation. So we have to perform maternal serum screening, prenatal sonography screening, and sometimes if we receive the sample from the child, previous child, to detect mutations, then we can perform prenatal diagnosis. Environmental defects like prenatal exposure to teratogenic drug or infectious agent. For instance, if a lady has epilepsy and they are treated with sodium valproate, they have to stop that medicine at least 3 to 6 months prior to pregnancy. Otherwise, their fetus will be affected and malformed during the pregnancy. Infectious agents like toxoplasma will cause, a lot of time it causes miscarriage, or rubella, CMV or HSV, they could cause defects in the fetus. So we normally do testing, laboratory testing for these infectious agents, which they call TORCH syndrome, toxoplasma, rubella, CMV, and HSV. Normally we have to do testing. But sometimes if they are suspected of these infections, we can also do amniocentesis and test for these infectious agents during the pregnancy. As you can see in this diagram, there is exponential increase in trisomies in the fetus of mother with advanced age. After 35 years old, the risk becomes several times higher than the age 20 to 30. In this chart, you can see at age 20, 1 in 2,000 for Down syndrome. Age 35 is 1 in 350. And at 40 years old, 1 in 100. So right now, the age of marriage has gone up, and therefore the pregnancy is higher a lot of times than 35 years old. So there is a recommendation that instead of doing the biochemical testing, we do NIPT, non-invasive prenatal test. We don't have to do amniocentesis all the time for the mother with advanced age, but we can check the cell-free DNA, which I explained in the next slides. And this has a very accurate detection rate with minimal false positive. So risk of Down syndrome with increased maternal age in pregnancies with mother age over 35, it is recommended to perform maternal serum screening using non-invasive prenatal test, NIPT. This will prevent unnecessary amniocentesis because of no false positive result of NIPT. I translated some of these Persian slides, and this is the translation. For maternal serum screening during pregnancy for diagnosis of chromosomal defects, first trimester, following genetic counseling, if the couple requested MSS, we will perform the combined test, which includes a nuchal translucency sonography, NT, and usually nuchal translucency should not be more than 2.5 millimeters, is the accumulation of liquid behind the neck of the fetus, which is measurable by this sonography. Then immediately after sonography, we perform the laboratory testing for free beta HCG, human chorionic gonadotropin, and pregnancy-associated plasma protein A. MSS only shows the risk of chromosomal defects, and it requires confirmation using amniocentesis in order to terminate the pregnancy. So we have to perform either karyotyping if we have time after amniocentesis, or perform FISH, which I will talk about in the next slides. Now, the MSS for second trimester, following genetic counseling, if the couples requested MSS, we will perform the quad marker test, which is performed at week 15 to 16. The quad marker, we measure 4 items in this test: free beta HCG, alpha fetoprotein, unconjugated estriol, and inhibin A. And so here, doing the second trimester testing plus the first trimester combined testing, we usually have detection rate of about 85%. And all these testings, including the information from the mother and the gestational age, is entered in a software. For instance, here it's called antenatal screening software called Alpha for Down syndrome, neural tube defects, and preeclampsia. It can give you information on all these diseases, and then we give a risk calculation sheet to the patient, which here in this slide, it tells you what gestational age each different biochemical marker can be measured for beta HCG, free beta HCG, PAP-A, unconjugated estriol, inhibin A, and alpha fetoprotein. It gives you the exact gestational age that can be measured. So past 13 weeks and 3 or 5 days, you cannot measure PAP-A. So the first trimester maternal serum screening has to be done no later than gestational week 13. And the quad test can be only done past gestational week 14. The optimum is between 15 to 16 weeks. This is a calculation risk analysis for Down syndrome. As you can see, that it has various information from the mother and also the previous pregnancy data, previous neural tube defect, previous Down syndrome, previous preeclampsia, insulin-dependent diabetes, smoker, maternal age at the time of the gestational age, 31 years old, scan measure, gestation at date of sample, when the blood sample is taken. Her gestational age for the fetus was 13 weeks. Weight, woman's weight, 59 kilogram. Nuchal measurement is 1.44 millimeters. So the data from the sonography has to be entered. Then the measurement is for each protein or hormone is written here also. PAPA level, free beta hCG, which is compared with minimum of median in the population. So you have to have a population median of minimum of median, which is calculated for the population. Each population varies. So the interpretation here, the screen result, it says screen negative, risk of Down syndrome less than 1 in 20,000. Now remember, this is a very good risk and it's very low, but the detection rate for doing this, only this sonography and combined testing, is only 80% at this point. According to New England Journal of Medicine, where they did this kind of testing for 5,000 ladies and reported the detection rate and false positive. The false positive rate is about 5%. So if they do 100 ladies who are pregnant, they do maternal serum screening, and 5 of them will do unnecessary amniocentesis, which turns out to be negative at the end of the testing for amniocentesis. So 5% positive is a lot. This is a screen that's done for the second trimester. The software included all the information for the ladies. This is a different lady. Maternal age is 46 years old. So she became pregnant with a very advanced age. Now the gestational age to do the sampling is 14 weeks and 5 days, which is valid. And all these measurements, it shows the screen result screen positive. So let's look at this red bar here. The risk is 1 in 20 for Down syndrome. So with this result, we have to perform amniocentesis and either karyotype or FISH to confirm the results in order to do pregnancy termination. The cutoff for Down syndrome is 1 in 250 according to the Ministry of Health in Iran. So in each country, the cutoffs may vary according to the population. Okay, the patient with high risk for SLOS in second trimester. So there are very minimal single gene defects that can be detected in this screening, maternal serum screening. One of them is Smith-Lopitz, Smith-Lemli-Opitz syndrome, where the risk here 1 in 6. So the calculation of the software with the measurements, especially the unconjugated striol, which is the key diagnostic factor for this syndrome. And so this is the definition of this syndrome: Rutledge lethal multiple congenital syndrome. The symptoms include polydactyly, sex reversal, renal hyperplasia, and unilobar lung. It's caused by homozygous or compound heterozygous mutation in the gene encoding sterol delta 7 reductase, DHCR7, on chromosome 11q13. It is an autosomal recessive multiple congenital malformation and mental retardation syndrome. Although historically a clinical distinction was often made between a classic type 1 disorder and a more severe type 2 disorder, in reality the syndrome constitutes a clinical and biochemical continuum from mild to severe. So these are the pictures of some of these children with this defect, the multiple congenital, which shows all the symptoms that I listed in the previous slides. Mutations occur in the gene encoding sterol delta 7 reductase. And if we detect in maternal serum screening, the pregnancy termination is in order, but we have to receive a fetal sample to detect the mutation for the future pregnancy. Remember, if we do not have the mutation for the disease, we will not have any means to do prenatal testing of this syndrome for the next pregnancy. We always have to receive a fetal sample for the future pregnancy prenatal diagnosis. In this graph, a bar graph, you see the false positive rate for different combination of maternal serum screening. So if we do more combined testing, then we reduce the false positive rate. But if we only do, for instance, some OBGYN experts, they only do the NT, nuchal translucency sonography, which has 20% rate of false positive. As we include more testing, like double test, triple test, quadruple test, along with PAP-A, we reduce the false positive rate. So what is NIPT, or the measurement of DNA, fetal DNA in maternal plasma, cell-free DNA in maternal circulation? So here it shows maternal plasma, which includes both maternal blood cells DNA and also placental DNA, which is the fetal source. So both cell-free fetal and cell-free maternal DNA circulate in maternal plasma. Cell-free fetal and maternal DNA circulate in maternal plasma as relatively short fragments, 150 to 200 base pairs, and represent the entire genome. Fetal DNA comes primarily from the placenta, and maternal DNA comes primarily from maternal blood cell. This is very important. The last note that I included on this slide, fetal DNA is 5 to 20% of the total cell-free DNA. And on the average is about 10% in maternal plasma is fetal cell-free DNA. When we do this NIPT testing, the fetal fraction, DNA fraction, has to be no lower than 5%. Some companies, when they do the testing, they say they have validated as low as 3 or 4%. But I like to see the cell-free DNA fraction higher than 5% in order to have a valid testing. Now, what is the advantage of NIPT? I listed here in English. Advantage advantages of NIPT compared with common biochemical screening during pregnancy. Lower false positive in NIPT, detection rate of greater than 99% for common chromosomal abnormalities 13, 18, 21, and XY, no risk of miscarriage due to only blood sampling from mother, no conflict from previous pregnancies because fetal DNA is cleared in short time. This is very important. So within a few days, the previous pregnancies DNA is all cleared immediately after delivery. Fetal sexing is also performed with NIPT with 98% accuracy. NIPT can be performed for 10th week of gestation. However, the optimum time is after we do the NT sonography on gestational week 12 to make sure that the sonography shows normal fetus, and then we do the NIPT. Saves time and cost, and it's only done one time past this sonography. It does not, we don't need any more maternal serum screening. Reduces anxiety and stress in the family. So sonography for anomaly scan, I translated it here. Sonography fetal screening in the second trimester, fetal anomaly scan. This is so past the NIPT testing. Once we receive the result of NIPT testing and it's normal, then the last thing that we can do for making sure that the fetus is normal it's the fetal anomaly scan on week 18. When I say the last thing we can do in regards to the legal abortion time in Iran is 18 weeks and 6 days. So that's the last thing we can do prior to that date. And if the fetus is abnormal in this fetal anomaly scan, they can issue the approval for pregnancy termination. This is a more accurate sonography performed on 18th week of pregnancy. The following fetal organs are carefully examined: bones, heart, brain, spinal cord, face, kidney, stomach. In this scan, the following diseases are evaluated: spina bifida, cleft lips, palates, anencephaly, ampholycele, hernia, heart defects, kidney agenesis, skeletal dysplasia, and gastroschizy. Some diseases are diagnosed in week 22 to 24, but because of the time limit for legal therapeutic abortion in Iran, we have to perform it on 18th week. Now, according to the studies performed for various syndrome, nasal bone is a very key symptoms if there are defects in nasal bone. In sonography, fetal nasal bone is checked during the NT sonography on week 12, and it has to be present. In fetus with trisomy 21, nasal bone is not seen or it is hypoplastic. Study shows approximately 60 to 70% for Down syndrome, 50% in trisomy 18, and 30% in trisomy 13 has no nasal bone. Okay, up to now, we have performed all the maternal serum screening without any need for invasive technique. But once we have to confirm the defects, chromosomal defects or other type of defects, then we have to perform fetal sampling. So first we perform the sonography. If the fetus is in the right condition and normal condition, then we perform either chorionovillous sampling, CVS, which is done, the optimum week is 12th week. 10th week is more risky. And the risk of miscarriage from this sampling is between 2 to 3%. It's higher than amniocentesis. It can be done transvaginal or transabdominal, like it's done for amniocentesis. Now, a lot of times we have to do molecular testing, which requires more time. It's preferred to do the CVS sampling. But if we want to do karyotyping or fish testing, amniocentesis is preferred, especially for confined maternal mosaicism, which is higher in CVS, CPM, and it's much lower in the amniocentesis, especially if we do amniocentesis culture. It's performed between gestational week 14 to 16. The risk of miscarriage is about 1 to 2%, so it's lower than CVS. And usually the withdrawal of amniotic fluid is 1 cc per gestational week, which does not affect the fetus in adverse effects. Now we culture various cells in the laboratory for chromosomal abnormality detection and karyotype testing. We can do karyotype testing from whole blood, fetal tissue, CVS, amniocytes, product of abortion, other tissues with live cells. Remember that the CVS for karyotyping, a lot of times it could show confined placental mosaicism, which gives you the defects, wrong defects. Here it shows the amniocytes in the culture, healthy amniocytes, which, healthy in the sense of morphology. We don't know the genetic testing yet. So once they're confluent in this level, we can harvest them and go through the protocol for metaphase chromosome isolation, and then we can detect the test. So the harvest is done in a confined environment with the controlled temperature and humidity. The humidity has to be high, and we do the amniocyte harvest or any other type of cells that we culture. And remember that the dissecting microscope is very important in the laboratory, in the cytogenetic laboratory, for cleaning up, especially the CVS sample, chorionovillous sampling, where we clean up all the maternal blood from the CVS, the chorionic villus, and once we harvested the cells and go through the protocol of G banding, GIMSA banding, then we can do the analysis on automated analyzers under microscope, where the softwares will give you the picture of metaphase, and automatically this software will line up all the chromosome from 1 to 22 and X or Y, and that is called the karyotyping. When I was a student, I had to cut on print these and then cut each chromosomes from the paper and align them. Now everything is done automatically on the softwares. This is a karyotype for abnormal karyotype, which the fetus is affected with Down syndrome. 96% of Down syndromes have free extra chromosome 21. So the cytogenetic writing has to be 47XX, which shows the sex of the fetus, and comma plus 21. This shows that there is the extra chromosome 21, and 96% of Down syndrome fetus are accidental during the first few weeks of gestation. 4% are like this. 4% of the Down syndrome children. The Down syndrome Robertsonian translocation is shown here in the fetus, where two chromosome 21 are connected like this, plus, so one gamete, either ovum or sperm, will have the Robertsonian translocation, and the other gamete will have the extra chromosome 21, which results in Down syndrome. Usually these children with Down syndrome have more severe symptoms, lower IQ, and also a lot of times they could be result in a miscarriage. This is another abnormality, aneuploidy, which was detected during the pregnancy in my laboratory. It's called Turner syndrome, so which is the monosomy X. One of the chromosome X is deleted. The nomenclature is written 45X. Now there is another change in the chromosomes of the fetus. In version 9, the short arm of P11, band 1, subband 1, and Q13, which is shown here. One in the chromosome 9, there was a cut in the short arm of the chromosome P, and one cut in the long arm of the chromosome, and then it turned, so which is called inversion. Now this is actually not abnormal. It doesn't cause any disease, so there is no clinical significance. Therefore, we call this a polymorphic change. Polymorphism can also be seen in chromosomes, human chromosomes. We see this in a high percentage of the population. Remember that the polymorphisms could be associated with some problems such as miscarriage. We have published a data from about 4,000 cases in northeastern Iran, where we showed that this inversion, the ladies who have this inversion may have higher chance of miscarriage. So it's not causative, but it's associated. This is the fluorescent in situ hybridization, detection of Down syndrome. So we have a chromosome 21 probe, which is tagged with a fluorescent dye. Here it's the Texas red, where you can see 3 signals. And the nice thing about this testing, we don't need a metaphase. The cell can be in the interphase. Remember that we have to have a control probe as well, like chromosome 13 probe, which shows the normal copy number, 2 copies. And here it's a definite diagnosis, and the pregnancy termination can be approved by this testing. A lot of time the ladies come late for the for instance NIPT or whatever, maternal serum screening, or they after we do the anomaly scan sonography on gestational week 18, we don't have time to do karyotyping. Karyotyping takes at least 10-12 days to get the results, but for the fish we can do even in 24 hours. We can have this result to confirm the defects, chromosomal defects. Here is another case where interface fish analysis for trisomy 18, where we have two types of probe. One is the control probe, centromeric probe X, where it shows the green signal, 2 signal, which is normal in the 3 interface cells, and the centromeric probe 18, which is 3 signals here, and the diagnosis is definite, and pregnancy termination can be approved. Here's another microdeletion or for the Williams syndrome, which occurs in 7q11.23 deletion. So we have the control probe LS1 at this locus on 7q31, and the deleted area is LS1ELON, where you can see only 1 red signal and the 2 normal green signal. This is done in an individual, it's not in the fetus. So we can confirm the detection and confirm the syndrome, Williams syndrome. So for various syndromes, there are probes that you can order from the companies, and it's usually it comes in a kit where you can easily perform the fish. Another rapid testing for fetal fetus is the quantitative fluorescent PCR aneuploidy screen. So QF-PCR is done on amniocentesis samples. It can be done on blood, amniotic fluid, CVS, post-mortem tissue. Usually we test the short tandem repeat markers on chromosomes, 4 to 5 on autosomes of choice, 13, 18, 21, X and Y, used to detect numerical chromosome abnormalities. The advantage is that it's rapid result, 48 to 72 hours. Now, if you have a fragment analyzer or sequencing instrument, it can even be done in less than 24 hours with 99% accuracy. So a lot of times when the gynecologist or prenatologist they see a defect in their sonography and they want to confirm it quickly, they order the QF-PCR. Disadvantage of this test is it won't detect mosaicism, less than 30%, won't detect other chromosomal abnormalities, mechanism of aneuploidy remains unknown. Cells are cultured from amniotic fluid or CVS, DNA extracted and analyzed by the QF-PCR, reporting time 24 to 72 hours. Remember, the PCR primers are designed across the CA repeats, cytosine adenine repeats, and the STR, short tandem repeats. And alleles may have different repeat numbers. So if you get a single peak following the PCR and fragment analysis, we call this uninformative allele. when two alleles have different sizes, they're heterozygous, then we see a ratio 1:1, which is normal. These short peaks are not seen by the instrument. They are just mistakes of DNA polymerase non-templated addition of A. So we only see the higher peaks. With the trisomy, we see 3 alleles. So if it's informative, we can see 3 separate alleles, 1:1:1 ratio, and we call it trisomy. Now, sometimes 2 alleles, they are the same, homozygous, so it gets a higher peak, and a third allele is heterozygous, so we see a 2:1 ratio, where the trisomy allele 2:1 occurs. Now, spectral karyotyping and comparative genomic hybridization are more advanced molecular cytogenetics. Well, for spectral karyotyping, it's also called 24-color FISH, where the combination of fluorescent dye is used, usually 5 probes. Mixture of those probes will give you a distinct color for each chromosome. So this is especially done for cancer, where there's could be multiple translocations, and it can easily be seen in these. So comparative genomic hybridization is usually done for the fetus as well. Sometimes we do it for the fetus, where it can detect gain or losses in the chromosomes.